I need 10 volunteers. 10 volunteers, please. Or else I'll start calling names. I'm looking around, I know a lot of names. Dr. Duff, please come forward. Ladies, thank you. That's 3. We need 7 more. 7 more volunteers. All your clothes stay on, so it's all above the board. Thank you, Sherry. We need 5 more volunteers. Thank you, Bonnie. There's a very interesting row there. Thank you, okay. 2, 4, 5, 6, 7, 8. 2 more, please. There's got to be, I need to have either Dr. Green or Dr. Snyder. Need to have one of those 2. And then 1 more still. We need 1 more still. Could you take 1 and pass it on, please? 1 more, please. Dr. Fontana. Thank you. All right. All right, folks. Want to make sure everyone has a napkin. Thank you. Thank you, Dr. Fontana. Thanks. Hey, folks, a round of applause for these folks who are really good sports. Okay, this is what we're going to do. I'm going to give each of you a piece of ice, okay? And I'd like you to keep it on your napkin initially. When I start the timer, I will get you to grasp it tightly in your incorrect hand. Okay, so if you're right-handed, it's your left hand, okay? And we're just going to hold it for as long as we can. Everyone understand? Okay, so I'm going to give you the ice. You're just going to keep it on your napkin initially. And then when I get you to grasp it, I might ask you, please, to hold the napkin underneath so that there's not... Thank you. Dr. Duff knows how to take hints. Okay. Here's your ice, sir. Here's your ice. Here's your ice. Oh, that's small. I'll give you... Hey.
Oh, you give me a bigger one?
Yeah.
Thank you.
No worries. Oh, you're welcome. This is a first... Okay. More ice. Dr. Fontana, again, thank you. Okay, and I'm gonna do this too. Okay, folks. I'll get the timer going. Hold it in your left hand and grasp it tightly. Okay? Hold the ice in your, sorry, not necessarily your left hand, your incorrect hand, and grasp it tightly. If it gets too uncomfortable, you're welcome to stop. Just put the ice in your napkin and stop. No, that's not part of it, so no one should be uncomfortable unnecessarily. So if it feels uncomfortable, just stop. It's fine. That's not part of what we're doing. We're all winners, as it were. This is the whole session. Okay, and stop, folks. All right, so you can put it back in your napkin. Who felt discomfort? Did anyone not feel discomfort? No, everyone kind of felt some discomfort. Can I get you all at once, if we rate the discomfort from 1 to 10, I'll count to 3, and then you'll say your rating from 1 to 10 of the discomfort, okay? 1, 2, 3. Okay, there's a big range, right? So did anyone say 0 Or, no, no one said 0. So who said 1 or 2? A couple of people. Who said 2 or 3? Who said 3 or 4? Who said 5 or 6? Who said 7 or 8? Who said 9 or 10? Thank you very much. Now, I didn't think this through, but Catherine, is there garbage out the back? Yeah, okay. So you can wrap wrap the ice in napkin and throw it. Thank you very much, folks. Another round of applause. So, folks, the point that we're trying to make is that we all had the exact experience, but we rated the discomfort very differently, right? There were 6s and 7s, and there were 1s and 2s as well. So I just want to give that perspective that this thing that we're talking, so this session is about the opioid crisis, right? And opioid prescribing and opioid prescriber habits. So the thing that I want you to understand is this is difficult. If it was simple, we would have found a solution, but we're trying to manage pain. We all had the exact same experience just now, but we rated the discomfort so differently, right? And that's the environment into which we're trying to build guidelines and structure. So it's very, very challenging. So thank you guys for being here. So I want to thank our colleague, Dr. Paul Hilliard, for this ICE demonstration idea. So I want to introduce a couple of our speakers today. The problem is, if I really spent time describing our speakers, there would be no time for the course because we have really remarkable speakers. The first is Dr. Rebecca Haffajee, who you can see all the work that she's done and all the research that she's done. And these are my words, not hers. And you can disagree, but looking at her body of work, I think where her focus is how legal interventions affect health outcomes. And you'll hear more from her because, as you know, this state has had some legal interventions trying to influence prescriber practice. Okay, and the next person is Dr. Chad Brummett, who I think just stepped out, but he'll be right back. So if I could summarize what his goals are, I think, is to do everything and anything we can to cut the demand and supply of opioids, for opioids rather. So there's also, I also want to introduce Michael Herman, who I'm not going to tell you much about him because he's going to introduce himself a little bit. The thing, I don't know if you really know this, but we're so lucky to have these people in this room today. Dr. Brummett and Dr. Haffajee. In this country, so I'm fortunate to work alongside Dr. Brummett, and in this country there's about 12 to 15 highly influential researchers and thought leaders in the issue of opioid prescribing. And I would say Chad and Rebecca are 2 of those people. So we could have one course with just one of them and we would all learn a lot, but we're really privileged to have them both here. I don't know if you know how hard it is to coordinate their schedules and have them both here. But also, I think the most important person is actually Michael Herman, and you'll hear his story shortly. So please, Dr. Haffajee is a guest in our building, so please make her feel very welcome.
All right. Well, thank you so much for having me. Again, I'm Rebecca Haffajee. I'm an assistant professor of health management and policy at the School of Public Health here at University of Michigan. This is my 3rd year here. So I am a lawyer and also a public health and health policy researcher. I practiced in a former life, I like to say, and then I went back and did my PhD because I wanted to do, just as Ramesh described them, evaluations of legal interventions, and mostly I work in the behavioral health space and pharmaceutical and drug policies, and then also some other mental health and substance use disorder policies. So that's how I came into this world, and opioids have kind of overtaken my research agenda lately, which is well-deserving because they are so prominent and important. I'm also really privileged to come and speak with you. My mother was a dentist. She practiced at Forsyth Dental Center for her whole career. She worked in periodontal disease, but it's always fun to connect with dentists, actually. Okay, so today I'm going to be talking about prescription drug monitoring programs as a response to the opioid crisis. I'll give a little bit of background. I may actually stand here because I can't quite see the slides if I'm standing in there. I'll give a little bit of background to the state of the drug epidemic now because there have been some recent stats that have just been released. Give an overview of the policy responses to the opioid crisis, and then discuss the balance of the time on prescription drug monitoring programs. So these are the latest and statistics coming out of the CDC, the NCHS division there. These are age-adjusted opioid overdose death rates from 1999 to 2017. You can see that the trajectory, is this working? Maybe not. That the trajectory of the synthetics and many of the natural and semi-synthetic opioids and heroin have stayed somewhat the same from 2015 through 17, although heroin and the natural and semi-synthetics have stabilized somewhat. So the big story here is, we still have a lot of opioid-related overdose deaths happening. Overall, the drug deaths were about 70,000 drug overdose deaths, 47,000 opioid-related, and increasingly larger proportion of that is from the synthetics. So last year, or 2017, it was 28,000. That was a 45% increase over 2016. And then the prescription opioids, which we generally think of as those natural and semi-synthetic opioids, was held about steady at about 14,500. So in the grand scheme of things, as many of you know, this rate of deaths from overall poisonings and drug poisonings is now the leading cause of injury death. And it surpassed that of motor vehicle injuries in 2008. Drug overdoses are also the leading cause of death of Americans under age of 50. So this is probably the leading public health crisis of our time, and we're doing everything we can to try to get our handle on it. This was a recent paper that came out in Science, and what I found interesting is it shows the trajectory has really enjoyed an exponential increase since back in 1979, really. Their point was we've had actually a drug epidemic going on for quite some time, and we're attributing a lot of it to opioids in these most recent decade or two, but the increase had begun already. So that's one take on it. I think my take, and I suspect Chad will talk further about this, but that there is something exceptional about opioids. Their lethality is much higher than some of the other drugs, for example, benzodiazepines that we have seen on the increase, although the co-use of those two is very dangerous. And I think what's interesting is, there is this discussion that the synthetic illicits and fentanyls and the analogs have really taken over. But if you look at the graph on the side here, on the top are the prescription opioids, and the bottom are heroin. And heroin is quite similar to the fentanyls in terms of its geographic impact. So that's the overdoses attributable to those drugs. So you can see, and this was 2016, so it's still quite recent, although it's changed a little bit, but you can see that in many parts of the country, prescription opioids really are still the story. So I think we need to be aware that there's a lot of regional variation in terms of what local epidemics look like. It may be that in 5 years' time, the heroin and the illicit maps look like the prescription opioid maps, and that's some of what we've seen. Places like New England that started with more prescription opioid overdoses have now shifted to heroin, and a lot of what we think about that is that that this created demand and a market for these illicits, and therefore the illicit suppliers moved in. But we don't know. We don't know what's going to happen. But I think it's important to remember that they're almost related, but also distinct epidemics going on. This is also from this latest CDC report that shows the percent increase or decrease. So those states in blue are the states that are statistically higher than the US rate. Sorry, not increases in decreases, but higher or lower than the US average rate. And those in green are those that are lower. And so you can see Michigan, we are in the higher rate, and we have been for many years now. We're usually ranking within the top 15 states in terms of drug overdoses attributable to opioids when we rank the states. And this is the Michigan-specific trend. So you can see total drug overdoses on the top line, opioids in the middle, and heroin on the bottom. Those rates have increased, also that's through 2015, but they've increased through 2016 and 17. So for example, in 2015, you can see almost 2,000 Michiganders died of drug overdoses, the majority of which were from opioids. And in 2018, the most recent numbers, it's up to almost 2,700. So it is still continuing to climb in this state. And that's been a statistically significant increase, about 18% increase even in 2016 as compared to 15. So it just continues to increase here. So where are people getting these drugs from? And we don't have really recent nice pictorials of this, but the National Surveys on Drug Use and Health is typically telling us that people are getting, even those that are using heroin or illicit opioids, are typically getting first exposed with prescription opioids. Now that could be changing in some parts of the country, like in Massachusetts. I think that rate is thought to be a bit lower now for people using heroin when what they initiated with. But generally, we still think that the majority of people are first exposed through a prescription opioid of some kind. And sometimes that might be from a prescriber directly, and often it's actually indirectly. So the drug was prescribed to a patient, and then you access it through your family or friends. And so prescribers are really in this quandary where you're trying to balance pain and adequately treating that, and also think about this opioid epidemic that we have, and managing population health issues, also not over-prescribing or exposing a patient to risk. And so this shows you, this was unfortunately 2012, I don't have any more recent data, but so they've changed a little bit, but I think still the main message still comes through, that there are, some specialties are, as of the denominator of all opioids that are prescribed, are big prescribers. So dentistry ranks 6th there, but family practice is about half of all opioid prescriptions. But then on the far column, you can see that's using the denominator of how many opioids are these specialties prescribing as a proportion of all of the opioids, or I'm sorry, all of the drugs that specialty prescribes. Basically, how much of your practice is prescribing opioids. And there you can see sort of other specialties pop up, like pain medicine, emergency medicine, but dentistry, again, is still pretty high there. So really impacting on both fronts in dentistry. We know that there is a lot of regional variation, though, in this prescribing. This shows you at the county level, and even within Michigan, there's a fair amount of variation. So those counties in dark red are the highest prescribing counties. So Detroit used to be actually quite a bit higher. This was from 2015 and has gone down. So we even when we talk about the opioid epidemic, when we talk about states, even that to me is not the level of resolution that we should be thinking about, because it can even vary within a state. So policy responses to the crisis, and this is really what I focus on, have been. There's been a multitude, and I don't expect you to read all of this, but the main point is to give you a sense it's been a very busy space. So everything from the federal government and all of the agencies, all of the laws. Most recently, you've probably heard of the Supports for Patients and Communities Act that focuses a lot on treatment, that was just signed into law by the president. I think that states and local governments have actually been the most active on this front, and dominantly enacting prescription drug monitoring programs, or PDMPs, which we'll talk about in greater detail, but also a panoply of other laws as well. I think we've had about, about 500 laws passed between 2000 and 2016, 15, 16, at the state level. Then we've got insurers and pharmacy benefit managers doing things like claims analysis, formularies, and monitoring and reimbursement incentives. We have providers like you doing all sorts of things like urine testing, pain contracts, prescriber education and guidelines, sometimes implemented at your institutional level, screening tools, audit and feedback, all sorts of things. And then we have also at the national level drug manufacturers doing things like reformulations. They're participating in the REMS, prescriber education, through FDA, and they're developing new products. There's been a big emphasis in FDA and the federal government trying to get these drug manufacturers to innovate and get new both pain medications and treatments for opioid addiction. And this shows you just in using 4 data sets that I work with, so the 4 dominant state policies, including operational PDMPs in blue, and naloxone access laws, Good Samaritan laws, and pain management clinic regulations, sort of how the trajectory of how the adoption of these laws has increased over time. So PDMPs were already pretty prevalent, about less than half of states, but maybe 15 or 16 in 2000, but now all 50 states have them. Missouri sort of has one. And then others enjoyed later adoption, but like naloxone access and Good Samaritan laws, almost all states have those as well now, too. So lots of action on the policy front. But that should give you a sense that PDMPs really are a dominant state response. In Michigan, and you've probably heard about many of these laws because you're supposed to be following them if you're prescribing at this point, but just to recap, so the acute pain, and this is Chad's domain, there has been enacted as of July of this year a 7-day supply limit for new controlled substance prescribing. Pharmacists can give partial fills of Schedule II substances. Then on PDMPs, and we'll talk more about this in a moment, but we have to, before prescribing controlled substances for greater than a 3-day supply, prescribers have to access MAPS, or the Michigan Automated Prescription System, the Michigan PDMP, and access that report for a patient. They also have to be MAPS registered as of now. All prescribing, this actually has been pushed, this effective date, from March 31st. My understanding is now it's up to December, and LARA, the licensing agency, is going to be issuing some description of what a bona fide prescriber-patient relationship means, but generally you're supposed to have that, or going to have that for all controlled substance prescribing, and there's going to be a follow-up required or referral when you prescribe controlled substances. And then finally, this informed consent piece. Before issuing a new opioid prescription, prescribers have to discuss the risks. It includes a component of minors also, and signed consent to treatment needs to be documented. So this is a lot that Michigan did all at once. It's a big onus on prescribers, and I know that some of these pieces, particularly the bona fide prescriber-patient relationship, has been somewhat controversial. So let's talk about the prescription drug monitoring programs now, though. So these are electronic systems that digitally store, monitor, and analyze controlled substance dispensing information. 49 states have them. Missouri doesn't really have one. It monitors prescribers, but prescribers are not actually accessing the database yet. They collect information on patients, prescribers, dispensers, on Schedule II through 5 drugs, all sorts of details on the number of days supplied, the substance, the dosage, all of those sorts of things. Typically now prescribers and pharmacists can access in virtually all states. Law enforcement can access in almost all states, although the conditions under which they can access differ, and state medical boards typically can access as well. These programs actually started out in law enforcement agencies historically, and they've shifted really into clinical, so now most are housed, about 2/3 are housed in health agencies of some kind. Some are, quasi-regulatory agencies like LARA, Michigan's, so licensing and regulatory agencies, but a handful are still housed in law enforcement, and in those states, law enforcement typically can access the data with no restrictions, and it sort of tells you what the state's emphasis is in terms of why they have the program in the first instance. A few features that have been hot for states to adopt recently include what we just talked about with Michigan, this mandated registration with PDMPs. So this is as of 2017, which is why Michigan is not yet highlighted in blue, because it wasn't effective yet. So even as of this map, more have adopted it as of now. So that's a lot of states, 34 states and more now, at least 35, actually mandate that prescribers register, typically when they're actually actively prescribing controlled substances. Also, a few less require that prescribers and/or dispensers access the PDMP database in certain circumstances. What this map doesn't tell you, though, is that the circumstances vary a lot between states. Michigan's is actually on the edge of more stringent. Some other states have more exceptions. For example, they accept out all ED interactions. Many states exempt out hospice and palliative care. So there's a lot of different variation in terms of how frequently and regularly prescribers have to be accessing. So I'll talk a little now about the overall literature of evidence about the impacts of prescription drug monitoring programs. This is an analysis that I led. It was in Health Affairs earlier this year. We looked at a ranking system, so I actually took all the PDMP features over time and created a robustness scale, essentially, out of 10 features that either had an evidence base for these features or theoretically had grounding as to why they would be important for the programs to have clinical impact. So for example, being housed by a health agency as opposed to a law enforcement agency, having prescribers actually have access, because a few like Pennsylvania only recently gave their prescribers access, monitoring lots of, a lot of schedules of drugs. So for example, Schedule 2 through 4. So with 4, you can tell the interaction, the potential polypharmacy concerns with benzodiazepines, frequent data collection, and other things. Some of these already had a budding evidence base of the mandatory consultation or use of the PDMP and under comprehensive circumstances. So looked at all these features across states over time, came up with 4 states in pink that had what I designated as robust PDMPs during the study period, which spanned through 2014, and compared those to control states that had either no PDMP or weaker PDMPs. Also did some sensitivity analyses using different comparison states as well. So what we found, we were looking at prescribing in a claims database. We used both interrupted time series and difference in differences analyses. We found that consistently across all sets of states that the dosages supplied did decline. So in Kentucky, we saw the most significant results across all of our outcomes. We saw dosages. So here you can see, oops, sorry, I don't have a pointer, but in red is the Kentucky MED, morphine equivalent dosages prescribed per quarter across the whole commercially insured population in that state that met our criteria. And in the blue, you can see the control state was Missouri. So they had reasonably parallel trends beforehand, and then after the Kentucky implemented its robust PDMP, it dropped down to a level of what Missouri had in terms of the MEDs that were actually being prescribed per quarter. The absolute reduction by the end of the study period was about 77 MEDs per enrollee per quarter, but that's across everybody, including people who weren't getting opioids. And we saw a similar, so this black line in the bottom is showing you what the actual difference was between the states. You can see a similar drop in that trajectory in another comparison state of New Mexico versus Texas. More of a level shift down when we looked at Tennessee versus Georgia. Tennessee was the one that implemented the strong PDMP. And then we even saw a slight level shift down in New York. But New York, as you can see, had kind of lower levels of opioids at the baseline as well. And it's also its PDMP policy wasn't quite as strong as the others. It was still strong, but not quite as strong. We also we did some difference in differences and saw relative reductions of anywhere from like 10 to 20% along these number of fills, average MEDs that were filled per enrollee, and that was among a cohort that was actually filling opioids. We looked at high-risk prescribing, so people that were doctor and pharmacy shopping saw 20 to 40% relative reductions in the year after the policy was implemented as compared to before. So fairly significant results. So we concluded that robust PDMPs were associated with modest decreases in the proportion of the commercially insured population filling opioid prescriptions in these states. were also associated with decreased MEDs dispensed per enrollee. When the use mandate was less broad and was not paired with a registration mandate, however, the effects were not quite as significant as was the case in New York. So how does this compare to the rest of the literature? Generally, we find there's sort of mixed older evidence of PDMP impacts on both drug prescribing and health. Largely that's because the PDMPs were very low used in earlier years, and also some of the designs of those studies were not as robust for causal inference. Then more recent evidence comparing specific PDMP features that's stronger in design, and also these programs are much more used now. We've seen in states, across states that have implemented many of these features, they've looked at the registration before and after. I'll show you Michigan's in a moment, and that's significantly increased, and the queries to the database. So we know that the actual using the system is changing. So then we're looking now at the health outcomes. So generally, literature finds that the use mandates, you have to check. A lot of people have been focusing on that feature in particular. Decreased opioid prescribing, doctor shopping, and even overdoses in adults and the elderly population. That includes when they're paired with those pain clinic laws that regulate pain clinics. The overdoses has been a little bit mixed because it showed reductions in prescription overdoses, but perhaps an increase in illicit overdoses. So we're looking into that unintended consequence further now. Another state suggested that, a study suggested that registration mandates, so just requiring prescribers to have to sign up for the program, decreased opioid prescribing in the Medicaid program. Our study and others have now shown that registration mandates, robust use mandates, and delegate access decrease not just prescribing, but also high-risk prescribing in the commercially insured population. But really, this is where the action is now, is the unintended consequences of PDMPs. So what might be there's a lot of concern of if we reduce the supply, which I think we've shown now among patients, then are they simply turning to illicit sources instead? Also looking into how do these reductions vary along patients of different demographics? How do they differ by prescriber specialty? So that's kind of where the research is going now, but still not definitive answers yet. Also, there's a whole literature on PDMP impact on prescriber behavior. And generally this suggests, and this is mostly physicians, suggests that prescriber PDMP awareness is high now. In earlier studies wasn't as high, but now it's like anywhere from 72% of PCPs to like 90% even of some other specialties. Sometimes ED specialists and pain specialists. So awareness is high, and the use is still a bit variable, but definitely on the increase. And then some studies have looked at sort of how PDMPs impact prescribing behavior. The most famous is probably this Ohio study in Annals of Internal Medicine that suggests that among ED docs, 61% of patients received fewer or no opioids, 39% received more. So the big finding there, and there was a similar finding in a dental study that I'll discuss in a moment, but was that there's this assumption that people always reduce their prescribing, but that may not be the case. It actually that sometimes it makes you more comfortable, and you think this patient is not raising red flags. I feel okay about providing them with the opioids to treat their pain. So these are some sort of best practices, somewhat evidence-based, deriving from the literature. Now I just want to spend a few minutes on the Michigan MAP system and what we know yet, although it's in the early stages. So this is a timeline of kind of milestones. So in 2003, MAPS was created. In 2005, MAPS turned to fully automated requests. Before that, it was like faxing and then mailing, like individual person pulling all the reports and mailing them. And then in 2013, it shifted to weekly reporting of all the dispensing information, so getting more timely information. In 2011, it moved from the Department of Community Health to LARA in terms of where it was housed. In 2015, the Governor's Task Force on Opioid, for opioid recommendations recommended that MAPS be replaced, among many other recommendations, but they thought that it was not up to the task. And so in 2017, the new MAPS was launched. It had a new data vendor, Apris Health, and it's the PMP Aware EXE software platform. 30 states use this now, and Michigan also has the add-on NARCS Care, which does some additional, provides some additional predictive risk scores and algorithms, and some sort of makes the user interface more sort of intuitive. And then in 2018 was what we mentioned, the registration and use mandates went into effect for greater than 3-day supply. Right now it contains over 120 million records. The data are maintained for 5 years. Required reporting of controlled substance schedules 2 through 5 from prescribers who dispense these controlled substances, pharmacists or dispensers, and veterinarians. Response times when you're querying average from 0.4 to that should be 0.8 seconds. And many new phase 2 innovations are in the works. These include pilot integrations into EMRs or EHRs. I think University of Michigan is the first. Provider scorecards, de-identified reports, clinical alerts, so alerts sent to clinicians when you've seen a patient, for example, and they're exhibiting high-risk behavior. And then ultimately statewide integration into the EHRs and also the pharmacy dispensation systems, but those will take some time. So briefly, mass registration has increased significantly since these updates went into effect. You can see in green is when they did, so it's almost quadrupled in terms of the number of prescribers that are registered who are actually issuing controlled substances. For the first time in 2016, prescribing has actually decreased, opioid prescribing in Michigan, and that's later than the rest of the country because most of the country was more like 2010, 2012, so we were lagging behind, and maybe coincidentally, but probably not, our PDMP was not as advanced as many other states, so maybe gives you a sense that, this is obviously all not causal. It is, and we need to do some of these more robust evaluations, but these trends are suggestive that the PDMP could have something to do with that. Michigan residents receiving opioids was already reducing, but really reduced in the period from late 2016 through April 2017 when those MAPS upgrades went into effect. And also multiple prescriber episodes for prescription opioids, so the rate of multiple, seeing 5 or more prescribers and filling 5 or more prescriptions at 5 or more pharmacies in a 6-month time frame. That's a typical doctor and pharmacy shopping measure. So that also has reduced, was reducing before, but reduced even at a greater rate around the time when these MAPS updates went into effect. So I think we need to do more evaluation. We were just talking to Chad about getting the data so we can do some more, controlled comparisons. I think it's important that not just Laura and the Michigan government be doing the evaluations, but also unbiased folks to make sure that we can actually ascribe some causal reasons for some of these reductions to the PDMP. Generally, PDMPs in dentists, these are 2 of the probably more impactful studies I'm aware of. One was a Macaulay study, just came out, suggested that half of dentists surveyed in a national sample reported never having used the PDMP, often because of lack of awareness that it exists, that it was for them, and or knowledge about the registration and use. So that's probably a bit lower than physician prescribers. But when they use, they did find the information helpful about 60% of the time, or even somewhat helpful 30% of the time. Often it didn't change their prescribing. Sometimes they prescribed more opioids, 33% of the time, and sometimes less, 25% of the time. But the presence of the mandates specifically for PDMP use did actually increase the use more, including the first time you see the patient, but also for high-risk patients. There's a good evaluation of a use mandate in New York also, the iStop, which was one of the earlier mandates that went into effect. After adjusting for the frequency of surgical extractions, they found that the odds for a patient to receive opioid analgesics was reduced by about almost 60% in the 3 months after iStep was implemented as compared to that same time period in the year prior. And then when they looked a subsequent 3 months later, they found even a decrease of 72%. So all of this is suggesting, the main takeaway is that these PDMPs do seem to reduce prescribing. It may not always be in the best ways, so we need to target and make sure the policies are nuanced and look at some of these potential unintended consequences. But in my mind, that there's no doubt that PDMPs have had a big impact nationally to reduce prescription opioid supply, and I think that it's variable across different specialties, and dentists probably maybe a little bit further behind other physician specialties in terms of adoption, and I think we need to study dentists more, but we're starting to get similar results on the dentist front as for other prescribers. So thank you.
So in summary, I think that legislation works, PDMPs work, and the other thing is dentists and dental hygienists can affect legislation. You are topic experts, and our legislators, our senators want to hear from you. So I think that's the take home. Now, folks, there's a lot of things that we don't like about Michael Herman. He's from Ohio, and we don't like that. He is a student at Detroit School of Dentistry, and we don't like that either. But he is very kindly, he's a D4, a current D4, and he's very kindly taken time out of his curriculum, come all the way, battle the traffic, prepare a lecture, and speak to us today. So please make him feel very welcome.
Can everybody hear me okay? We're good? All right, cool. So like Dr. Nalia said, I'm Michael, I'm from Ohio. I'm a fourth-year dental student at Detroit Mercy, and I have the unfortunate experience of losing a loved one to the opioid epidemic. So my reason for advocacy, here he is, this is my brother, Sean Herman. He was born March 8th, 88, and he passed away, unfortunately, September 21st, 2017. That was within the first 30 days of my dental school career. He became addicted to opioids around age 21, and I'm here today to talk to you guys about that story. So we grew up in a really nice community called Bexley. It's in the middle of Columbus, Ohio. We had wonderful education, wonderful parents. One of the points I want to drive across to you all is that when people become addicted, addiction doesn't see color, it doesn't see socioeconomic background, it doesn't care who you are. When you become addicted, that's what happens. Your mind changes, your body changes, your thought processes change, your behavior, everything. So Sean graduated from high school in 2006. He graduated with top honors, went to the Ohio State University, boo, I know. And he started in the Scholars Program at the Fisher School of Business. And he unfortunately got into partying early. But at this point, it was just drinking, having fun. We all thought, good old boys, he'll calm down. Well, it didn't quite go that way. And he was out motorbiking with some friends out in the country, another Ohio thing. And he fell off his quad, or his friend's quad, and he really injured his back. Now, my mother had told him, do not go do this. You're in the middle of school, you have all these important finals coming up, you cannot miss anything if you hurt yourself. So what does he do but hurt himself, fall off, miss finals, but too proud to tell my mom. And instead of dealing with the pain by going to a doctor and actually dealing with the issue that was causing it, he talked to his neighbor, and his neighbor said, hey man, take one of these, this will really help. Well, it was a 10 milligram OxyContin. And that spelled the end of his life, that one pill. So why is that so important for all of us? We catch young people early, right? We take out third molars. All these things, we can impact their development if we prescribe too early. So Sean got this one pill in probably, I would say, 2011. From that, we noticed all these different behavior changes. He started missing family dinners. He started not being able to handle his own finances. And then we started finding things missing. He assumed my identity and cashed my bonds. He took all the gold from my mom's house and sold it for money for drugs. So we put him in rehab. In fact, I came home from college. I went to the University of Cincinnati for my undergrad. I had to come home because both my parents were working, and I had to take Sean to rehab. And he did really well. He worked all the steps. He worked the 12-step program. He was really improving, and he was going to all these meetings with friends from rehab. Well, unfortunately, what happens is a lot of the rehab facilities, they aren't actually doing what they say they're going to do. They prepare people to deal with the addiction, but then they send them out into the world necessarily not with the ability to handle and cope with all the stress. And then they've been getting used to dealing with stress and problems by taking these pills. So he finds out from his friends in rehab that heroin, hey, that's a lot cheaper than looking for an opioid. So he starts using heroin intravenously, and it got to the point where my family was pretty much in shreds. None of us agreed with how to handle him. So we sent him to Florida to a recovery unit down there. And he worked the steps again, and he got sober, and everything was going really well. But then the stresses of life came back, and the stigma of addiction came back, and he didn't want to ask for help, so he just started taking pills again. And then he got so bad in Georgia, we had to bring him home. Now this is the third time, mind you, he's going into treatment. And we've tried everything. He's living with my father, finally back on his feet, goes back to the Ohio State University, finishes up his degree, and starts looking for a job. Well, guess what accompanies a job? Lots of stress, no ability to cope. So he turns once again to opioids. And I remember it was 3:30 a.m. on September 21st, and I got a call from my mother, and my brother had passed away. And before I left, I looked him in the eyes, and I said, you don't have any more opportunities. You've run out of chances. You've overdosed as many times as you possibly can. So this is it. This is sink or swim. You have to figure it out. And I took away my relationship with him as a consequence, because that's the right thing to do in some instances to get across to someone. And unfortunately, that was the last conversation we had. And he passed shortly after. And then I have a few more photos because we had a great childhood. There we are together. We looked like twins. We were as close as could be. Unfortunately, that same day, my grandmother, the woman in the top left picture, came over to console my mom because I was on my way back from Michigan. And as a consequence of the shock of his death, she died in my mom's kitchen of massive cardiac death. So one of the points I want to get across to you all is we prescribe opioids. It happens. Some people need them. I don't think we should be prescribing them. But it's an addiction. It's a disease of the entire family, not just an individual. That one person, they're connected to maybe 10 people. They love a bunch of people. This thing will come back and affect everybody. Especially when we prescribe to young folks. So on that same message, when we prescribe, we're a lot of the times prescribing for third molar extractions. And when I was talking earlier about development and the ways that opioids may change the development of the brain, we see here that the major growth of the prefrontal cortex happens between 13 and 26. A lot of folks are getting their wisdom teeth out in that age group, but also there's a lot of folks that don't have access to dental care, that don't have money, especially in the millennial population, don't have a lot of money, low income. They're losing teeth left and right. We're doing a lot of extractions. And if we can avoid giving them opioids before they're old enough and they're developed, then we can stem the change quite a lot. Also, as you see here, adolescents can become addicted 5 times faster than adults. These are all people that we're seeing regularly. Like they were saying, every 6 months we're seeing these people. So if we can avoid giving them these drugs, we may have a huge impact. I don't know if any of you happened to open the ADA huddle this morning, but there was a study by JAMA that showed wisdom tooth extractions and opioids given, and 6% of all of the young folks given opioids for wisdom teeth extraction ended up with an opioid addiction. That's on us as dentists. That's not on medicine. That's not on anybody else. So we have a real opportunity here to affect change. And then, like I was saying before, of all the people that get addicted, this is almost 97% are under the age of 21. This is a delicate population that we're handling day in and day out. And then this is another thing. Genetics account for 40 to 70% of the risk of developing an addiction. So when you're sitting there and you have your 5 minutes where you're interviewing your patient, and for all my fourth-year colleagues who are about to go into practice, we all know we're trying to figure out, okay, what's their chief complaint, what can I do, and what options does that patient want to take to move forward with treatment. In that 5 minutes, how can you look that person in the eye and know, are they susceptible to this addiction? Am I going to give them this for pain and then, oh wait, 72 hours later, they're out, but they're also looking for it again. We can't. So we try to, a lot of it's going to have to be, getting our patients to accept a certain level of discomfort, but letting them know that we're also going to manage their pain. So on that topic, to compare the amount of people that are passing from opioid overdoses, in 2015, 52,000 passed from opioid overdoses, were only 30,000 from motor vehicle accidents. And this is from the CDC. So as of 2015, there were also 2 million addicts in the US that abuse opioid prescriptions. And that's not including the people that are seeking them on the street. So if you imagine, that number is much larger. So when this all happened to us in 2015, because my mother's a dentist, a lot of people in Ohio were asking us, what can we do? So one of our good friends, Dave Kimberly, he's a oral surgeon out of Akron, Ohio. He said, what can I do, Sharon? What can I do? That's my mother, Dr. Parsons. What can I do to help? And she said, prescribe less opioids. So he went and he looked at his records for that entire year to see what he prescribed. And this was his generic prescription to people that were getting extractions as adults for implants or for young folks getting wisdom tooth extractions. So he was giving Percocet or Vicodin, 5 milligrams with 325 of acetaminophen. He was giving them 20 and telling them to take 1 or 2 every 4 hours. So when you extrapolate that data out to show for an entire year, just for wisdom tooth extractions alone, from people in the age group from 15 to 24, there's 20,000 tablets from one office. Now when you add the ones for extractions, implants, biopsies, other adult procedures, it's another 21,000. So one office in 1 year was prescribing 42,250 tablets alone. So when you take that even further and you extrapolate that data out, say there's 300 surgeons in Ohio. Now this is applicable in Michigan because the epidemic's almost as bad here. And there are 200 in practice. If they prescribe like this one gentleman did, that's 8 million tabs written just from the oral surgery sector alone. Let's make that picture even bigger. So there's 7,000 dentists in Ohio. If you remove all the specialties and we're just focusing on dentists and saying dentists take out third molars, do extractions, implants all the time, and it's increasing as we go on, if they prescribed at 10% of the level of this one oral surgeon, that's 25 million tablets. So this is where we step in, as we have a great opportunity as dentists, as people that manage pain on a regular basis, to do something different and not give opioids. And the goal for all of us for post-operative medication is to minimize people's pain, but also the anxiety they feel. So there are great ways to do that. We can use long-acting local anesthetics, and now there's another one that's just coming on the market, just got FDA approval. It's called Exparel. It is a liposomal bupivacaine, and it lasts for 24 to 48 hours. We also make sure that our patients take NSAIDs regularly, 600 to 800 milligrams ibuprofen every 6 to 8 hours, depending on patient size. And then also tell them to use acetaminophen as well, 1 hour later, 325 to 500 milligrams. Acetaminophen, Tylenol. And then we got to decrease pain perception. So we have to educate our patients that, yeah, you might feel a little bit of discomfort, but we don't need to treat your pain in the level that you're expecting from an opioid. And there are studies going on. I know right now Rutgers is working on them, and there's one that has been out that postoperative pain is just as well managed by ibuprofen or an NSAID plus acetaminophen as with opioids. So why expose people that could potentially become addicted, then go use street drugs and end their lives unnecessarily when we can deal with their pain as is? And then if they have to come back and you have to use it as a rescue medication, okay, I understand that, but from the start, we can make a big difference. And what happened in this one oral surgeon's office, they called all those patients they did not give opioids to. Nobody asked for refills. There were less calls about pain and insomnia, no calls at all about nausea, and the patients were very happy, and especially parents were thrilled to see that someone in the dental community is caring, because all of our patients know the opioid epidemic is among us, and they're interested. They're all watching and looking to see, okay, medicine is making a difference. Other things are making a difference, but where are we in the dental community? So this is our opportunity to jump in and really help stem this tide. So, and one last thing, I want to make sure everybody takes away from today not to stigmatize addicts. If someone comes in and they're an addict, try to work with them and help break the stigma, because they're not going to ask for help most of the time. And a few little things to look out for among patients: if you think that they might be an addict, pinpoint pupils, the lack of ability to maintain eye contact with you during conversation, and if they know what drugs work best for them following procedures, but they don't have a surgical history to match. Those are good things to look out for. Those are all things that should be tipping your mind to say, okay, this person should not go home with anything. And now that MAPS is here, it's a great help. And that's all I have for you guys today. Thank you.
You know, when something tough happens to someone that you love, in many ways that's harder than when it happens to you. Because for yourself, you have some control of the situation. So, you know, I just want to acknowledge this moment again, because it is so much that you've gone through and your family has gone through, and we talked about it in a few minutes. So I just want to just remember and thank you for, you know, the effort in coming down here, taking time from your school. We don't take that lightly. Thank you very much.
Thank you for sharing that story. I'm sad to say that I travel around quite a bit, and I hear those stories probably once or twice a week. Unfortunately, I know, just based on the data, someone else in this room has a deeply personal story. I'm going to talk about opioids today, maybe a little differently than you thought about it before. How many of you were here for my last presentation? So several of you will recognize some of these data, but we do have new information. I actually will say, even though you may see similar slides, I think today you'll hear a different talk, because as we've moved forward and as we've experienced more, we've learned a lot, and I've really appreciated this opportunity to work with Ramesh and start to engage in dentistry, because I think while we're making big strides in surgery, you have an incredible opportunity in dentistry. And I think you have to seize this opportunity. And if you don't, we're really missing a chance to make a big impact on health. These are my funding sources. We have funding from NIH, the state, the CDC, SAMHSA. I have an unrelated patent that won't pay me anything ever in my life. And I consult for a couple companies that do make non-opioid analgesics, but I'm not here to talk about their products. I won't mention their products today, other than to say I'm interested in more companies making better non-opioid, non-addictive analgesics. So I'm supportive of that and happy to help them scientifically. So I actually won't repeat a lot of the background, because you've gotten a lot of great background today, other than to say I think what I probably said last time I was here was that 115 deaths per day. And when I first started, it was 78, and then the next year it was 91. When I was here last, it was 115. And these data are the brand new data from the CDC suggesting 134 deaths per day. And I usually start with a story, but I clearly don't need that story. I don't need to put it in context, other than to say I have heard many people tell stories of that first exposure from a dentist or from an oral surgeon, and how that tipped the scale and pushed them down a path of addiction, or from those parents who tell me about how their son or daughter became addicted through that first exposure and moved down that path and died. I think Rebecca already touched on the fact that we're seeing a decrease in prescribing, and across all states we're seeing these decreases, less new starts, less people on these high doses, but at that same time we're seeing a spike in mortality, again driven mainly by fentanyl and heroin. But I will actually maybe think about it a little differently. I liked what Rebecca said about how maybe we have two different epidemics, but I want to come back and look at the full picture, because the patient advocacy groups will say, you're decreasing prescribing, but mortality is increasing, ergo opioids prescribing is not related to mortality. we still have a substantial number of people dying every year from prescription opioids. And the current data, the available data, suggests about 80% of people who use heroin begin with a prescription pill. That may not be a prescription that may not be a pill prescribed to them, but someone wrote that prescription. I helped contribute to the opioid epidemic. I helped create the opioid epidemic through my well-intended care. And unless you're a student or just brand new into practice, you've probably directly contributed to the opioid epidemic. And I think it's that level of responsibility and that level of understanding that we have to make meaningful change. Because if we really look at the full picture here, in the mid to late 90s, we had this uptick in prescribing that went all the way to 2010, 2012, a point at which there was effectively a prescription per adult, not a pill. I mean, here in the state, we're still over one prescription per adult. Michigan Department of Health and Human Services estimates that there is enough unused opioids in medicine cabinets around our state for each adult to use opioids around the clock for 30 days. Billions of unused pills in our community. So this is still a prescription epidemic. And you have to have that personal responsibility. Simply talking about the fifth vital sign or JCO or the lies that we were told and continue to be told by some of these pharmaceutical industries is not sufficient. We can't simply just point to those things and say, look at all these things that disadvantage me and I've been screwed and now what am I supposed to do? Well, what you're supposed to do today is make change now that we've got a better understanding. Rebecca already touched on this, but these are the new data that just came out this week from the CDC looking at mortality. I think what's interesting is you see increases in every age group. Every single age group you see an increase in mortality, and especially those people less than 55, the 25 to 34. There's a lot of teens and adolescents dying. But I think what's different about this epidemic as compared to the last time we saw a 3-year drop in life expectancy, World War II, our greatest generation. That was the last time we had 3 consecutive years of decreased life expectancy. Except I was just in Chicago, and I went through a really cool portion of the Science and Industry Museum that was really talking about these heroes. I don't think we're going to have a museum dedicated in the same way to all the young people dying today from opioids. This was a very different time. But this is the last time we saw this type of death and despair. I think some of you remember this, but we take a different approach. Our group, Michigan Open, decided that most of the country was very focused on all these downstream effects, what to do with opioid addiction, what to do with dependence, how to better manage chronic pain. And we are in this space. I will just say broadly, our research group is doing work in all of these spaces. But until our group came together, no one was really asking this question. How often does that person coming in not using opioids end up going down a path that leads to addiction either for themselves or from a friend or family member or someone that they interact with? And I put a surgeon here, but the reality is we could replace this with a dentist or an oral surgeon. These are acute exposures. Right now we know for surgery that happens over at the hospital, the 2 factors that will predict whether and how much an opioid a person will get is the type of surgery they have and the surgeon caring for them. Nothing about them as an individual. There's still a piece of ice up here. It doesn't matter if I squeeze this ice and I'm a 9 or if someone else is a 1. And in some ways, or whether I have anxiety or depression or maybe even a history of substance use disorder, those factors are really not currently accounted for in how we prescribe and how we manage. And I won't sit here and tell you today what dentists do or what oral surgeons do other than what data we have. But my sense is, because we're all very similar in the way that we practice, it's probably pretty close to the same as what's happening in surgery. It's the kind of case you're doing and the specific dentist or oral surgeon taking care of them. Well, these are new data from our group. You did not see these last time. These are data that show that over a 7-year period in a large private payer data set where we actually merged together medical claims and dental claims. And this is actually unique because there aren't many data sets out there that allow us to merge medical and dental claims together in the same individual. What we see is over this 7-year period, probably based on the preamble to the CDC guidelines, that this yellow box here, which is mainly primary care physicians, was decreasing. The number of new prescriptions written to people not taking opioids, so this is effectively an index fill over a year's period, was decreasing. By comparison, surgery was increasing, but so was dentistry. The relative contribution of dental prescribing was increasing. Moreover, if we look at how much was being prescribed, dentistry stayed fairly flat, but there's no signs of decrease. Surgery went up massively. In fact, had a big tick up after hydrocodone was rescheduled. The net effect of hydrocodone rescheduling, now I can't call it in on the weekend. I need a token. Well, that decreased primary care prescribing, but it actually increased surgical prescribing. Now it's a Thursday, now it's a Friday, now I'm worried I'm not going to be able to get this to you on Saturday or Sunday. I'll just give you enough so you don't run out. Now, I'm not even going to ask because I know I was taught just give them enough so they don't run out. And my sense is that a good number of you have throughout your career, with the best intent, taught people just to give them enough not to run out. Moreover, if we look at the last 2 or 3 years of prescribing, primary care physicians not only were prescribing less, but they were less often, but they were actually also prescribing less opioid. But there's no signs of decrease. I read from the ADA in the lay press all the time that dental prescribing is decreasing, but I don't know the data source. Because right now, to my knowledge, there are no data sources that dentists are actually prescribing less. Nor are there any data sources to suggest that surgeons are prescribing less except for the new data that we have here in our state. Right? So I believe there's opportunity, and I believe this will happen, and maybe this is already happening in 2018, but through the first half of 2017, the national data don't suggest that people are behaving differently. I always talk about how surgeons think, but I could flip it around now and say what you think as a dentist or a neurosurgeon. I think the same way as a pain physician. I worry about time. I worry about cost. I worry about satisfaction. And if I'm a private practice dentist, where I know in Ann Arbor there are many, I want to keep people satisfied. I want to make sure they go back to their primary care physician, they like me, and they send me more patients. We know from qualitative interviews with both surgeons and dentists that this drove prescribing. These concerns drove people to prescribe more opioids. There are other factors. Sure, fifth vital sign did it. The idea that you couldn't get addicted if you had real pain, even though that's not true, that drove prescribing. But these factors drove prescribing. Well, these data are from surgery, and we're trying to replicate these data in dentistry, and Ramesh is going to show you some data from your own clinics here today soon. But when we look at the number of pills prescribed, there is no association between the number of pills prescribed after surgery and a person's satisfaction with their care. Nor is there an association between the number of pills prescribed after surgery and the likelihood of refill. Let's unpack that, right? Surgery, do people ever call and say they're unhappy with their care? Absolutely, right? There's no question. And do they go onto Yelp sometimes or into some of these social media and complain about you? Yes. But prescribing more to make people more happy is not a data-driven activity. You are not having a net increase or a net improvement in your satisfaction by increasing opioid prescribing. Is it possible? In fact, I would guess if I took a show of hands, all of you have probably had a patient in the last couple of years who has been unhappy with you in part because of the way you prescribed or did not prescribe opioids. Again, though, that's anecdote. If we go to data, there's no association. In our pain clinic, where we actually wean people off opioids frequently, we don't incentivize our clinicians so that we're not running around putting needles in everybody who doesn't necessarily need them. Our last patient engagement survey was 99.7%. It's among the top of the institution. We used to hover in the mid-80s. I used to ask for a 7-point modifier because we deal with such a high-risk, challenging population. And what we did, and I don't get any money from them, and I might have mentioned it last time, was we consulted ZingTrain. We started thinking about our patients in the pain clinic like customers walking in the front door of Zingerman's. We started to enable the 10-4 rule. If I'm within 10 feet of you, I'm going to smile. If I'm within 4 feet, I'm going to say hello verbally. We started acknowledging that when people are standing behind a desk and I'm typing at the computer and not acknowledging that they're standing there waiting for me, that's not great customer service. Certainly happens with Delta periodically, right? Why do we think we should treat our patients any differently? Forget pills. Think about them as customers. Not only that, think about your fellow employees and your students, and if you're a student, your faculty as customers. If we all started treating each other in a different way, we could improve our patient satisfaction. And we've done that. 6 years running, real commitment, real time, but incredible results. Also moved from a clinic that lost money to now $2 million a year profitable, and have the highest employee engagement surveys in the institution. We were in the lowest tier to begin. That's customer service, and that'll take you a lot further than opioids. In the same way, if we unpack the refill rate and we looked at less than 6 pills after a major abdominal surgery, or more than 60, it's about 7% of people call for refill. And it doesn't matter if we try to adjust it or do it without adjustment. It just means like 7% of the time people call for refill. In fact, I will actually argue that we start to see a slope in the data that's not significant, so I won't go too far with it. But as you get to higher numbers of pills, you start to see maybe higher refill rates. Well, that's actually not that shocking, right? If you get a person tolerant to opioids and they stop taking them, what happens? They withdraw. And whether it's real pain or not at that point, they don't feel good. What do they do at that point? They call you for a refill, or they go to the ER, or they see their primary care physician. Now they go back to their primary care physician, and you were the one that prescribed the first opioid, and they're asking for a refill? How do you look then? It's not good. Well, those that were here last time know that we're also interested in this concept of new persistent opioid use. People coming in not using opioids who go down a path of new dependence. Not necessarily addiction. I can't tease out addiction from these data. But we know, looking at major and minor surgical conditions, about 6% of people coming in not using opioids keep filling long past what we've deemed normal surgical recovery. And there was no difference between major surgery and minor surgery, suggesting that this is not just surgical pain. This could be other pain conditions, which we do see associated. Maybe my family doctor's not giving me opioids for my knee pain, but I've got knee pain, and oh, by the way, I got it now for surgery, and I'm going to keep taking it. We certainly see people taking it for sleep. And then there's mood, and mood isn't always to get high. When we talk to people who have moved down the path of opioid use disorder or opioid addiction, sometimes it was about just leveling out. I'm an anxious person, I don't feel right. I would take opioids, and we know that opioids actually temporarily decrease anxiety. But over time, that's a slow spiral down. And then pretty soon what you're doing is staving off withdrawal, and then you move down a path of heroin, and we've heard the story. 4% of knees and hips, these are knee and hip replacements, a very successful surgery, something that actually improves pain in many people. But whether your knee got better, worse, or stayed the same, it didn't matter. If your knee pain improved a lot after your knee replacement, you were just as likely to be on opioids 6 months later as compared to a person whose knee got worse. Again, this is not the surgery itself, it's the individual. 13% of hands, 13% of spine surgery, 4.8% of teens and adolescents undergoing elective pediatric surgery, 10% of curative cancer surgery. We forget we cut out cancer in the US a lot. Cancer survivorship is one of our new challenges. And 19% of women undergoing breast cancer surgery, certainly our most complicated cohort up here, in that there's lots of post-surgery treatment, chemo, radiation, and sometimes subsequent surgery. But if I put it a different way, we could consider becoming a new chronic opioid user the most common complication after elective surgery, and yet a complication that if you've had surgery was probably never described to you. And if I flip it around and put you in the driver's seat, that you've probably never described to a patient. And yet, as Michael described today, Alan Schroeder published an article today in JAMA Internal Medicine looking at kids 15 to 25 undergoing dental procedures and getting a dental prescription, and showed about a 6% rate. A different definition and a little bit more loose. We had just shown this in JAMA earlier this year, and some of you might have seen this. In fact, I hope you saw it. In other words, I hope it came through your channels. We looked at, Ramesh was part of this article, we looked at 70,000 kids 13 to 30 who underwent wisdom tooth extraction. This data went all the way through 2015. And after adjusting for demographics, pain diagnoses, psychiatric diagnoses, medical comorbidities, and the impaction status of the tooth, 1, 16, 17, and 32, still got it, we found that there was an adjusted 2.7 times risk of becoming a new opioid user if you got a fill as compared to those who didn't fill. Getting that fill, this is not, I can't ascribe causality here because these are association data. This is independent association, right? That's pretty strong. And that should give you pause. It should give you pause especially when you are so far ahead of where surgeons are in that you have randomized control trials showing that acetaminophen and ibuprofen taken together are at least equal and in some cases superior if you consider the ill effects of opioids. Why in 2015 were 80% of kids still getting an opioid as a part of this care? We have randomized control trial, level 1 data to say opioids are not effective in treating dental extraction pain. 80% of kids get them, and there's an adjusted risk of becoming a new persistent user. I was certainly more tempered in my last presentation than I am today, and I am becoming more bold. We bought a URL. We bought a URL for dental prescribing recs. You know my big challenge right now is as I think about populating that website, I don't know what number to use except for 0. 0 pills as a recommendation. Because right now, while I do think that there are exceptions, and I would never want to get into cookie cutter medicine where you're told how to prescribe, I don't believe that anybody should ever be in a position where we can't use good clinical judgment. I think a bold and appropriate goal for the School of Dentistry would be to say that a very small percentage of the patients coming in for extraction leave taking an opioid. I think that's what's data-driven right now. And I think it's appropriately responsive to the worst public health crisis in our time. We've improved prescribing and surgery, and I'm going to just tell you a story you might have seen last time, but it's a good story, so I always love a good story twice. We looked at gallbladders at the University of Michigan, and we decided that we would take this because it's a common surgery performed pretty similarly between physicians. Port sites, we hopefully should have reasonably predictable pain, acknowledging the inter-individual patient-level differences. We found that 50 pills was the average number of pills prescribed after a laparoscopic gallbladder removal. Now that shocks people when I go out around the state talking about this. 50 pills, oh, that's a lot. Well, I looked at the data from the first half of 2016, all the way actually to the first half of 2017, again in Truven. And the national average is still about 42 pills, 2017. So that even is after this. And what we found was that 50 was the average prescribed, but the mean was 10, and the median, because the data were not normally distributed, was about 6 pills. Now, we were early in our efforts. This was run by one of our medical students, who I always joke was an M4 with tenure because he's just so bright. But we thought, gosh, if we could go from 50 to 15, 15 was going to satisfy 75% of people, and that'd be a big change. If we could do that, that'd be pretty cool, and that seems like it would have a good benefit. And so we did something pretty simple that I don't think is scalable, but we just wanted to be simple, clean, easy. We did a voiced-over PowerPoint by that intern who then, this chair of surgery made all the residents watch it, and sure enough, over the next year and a half, 15 became the new average prescribed. Incredible. 15, and if I showed you the plot, the standard deviation is really tight. And what I don't show you here is that armed with data, these residents also now started decreasing prescribing for lap appy and thyroid surgery and lap gastric bypass. They just needed context, right? So I think what this shows is the power of a QI intervention to give people context, because where did we ever come up with 50? Well, it was literally a number someone made up. There were no data to ever drive 50 pills. When we did this, we saw that there was no change in refill. 4% was the refill rate before and 3% to follow. no change in self-reported pain over the week to follow their surgery. And when we gave people less, they took less. And some of you will remember this part. We gave them 50 before they took 6. We give them 15 now and they only take 4. And it is a statistically significant difference. And it didn't matter whether we adjusted for acetaminophen and ibuprofen, patient factors. There wasn't really anything that seemed to be driving this other than just the pill size. We've now published an article recently in JAMA Surgery looking across the state. The strongest predictor of how much people used from these statewide data was the amount that they were prescribed. Same thing for women undergoing cesarean section from a group from Harvard. The more that women got after cesarean section, the more pills they took, but with no differences in pain, satisfaction, or refill rate. The data are strikingly consistent, and the data from dentistry are also consistent. So we look around and say, that's only 2 pills, but let's think about what that could look like if we go forward and think about bigger surgeries. It could be really big, and this is all rooted in a social psychology construct called anchoring and adjustment. Normally, if we were having lunch here, I would point out the fact that you wouldn't normally grab a cookie, but if they had served lunch today and there were cookies there, you would have a cookie, right? We are doing the same thing with patients. When we send them home with 20, 40, 60, 80, 90 tablets, let's take it in your dental clinic and say, okay, I've got a choice now. This person might need an opioid, and I do believe that can still happen. I'm not saying that this should be a never phenomenon, but it should be very rare. What does that mean? Does it mean 2 pills, 5 pills? I think if it means 20 pills, you're telling that person, hey, by the way, this is going to hurt, and you need to be taking some of these. I know that's true when we give patients 90 pills, and we've heard that directly from patients. We have to realize that when we give people more, they're going to use more. We're in an antibiotic culture where we've taught them to finish all their pills. If we think about the context of that intervention, that's like 13,000 pills not in our community. I won't spend a lot of time on this other than to say that our group is networked with all 73 major hospitals in our state through a Blue Cross Blue Shield funded collaborative structure where we actually take this sort of CQI, full CQI model. We're going to make new recs. We're going to see that it reduces prescribing, and then we will hopefully reduce consumption. And when we see that patients are taking less and that there's no ill effect, because we monitor patient-reported outcomes, we monitor satisfaction, we monitor pain. When we see that they can take less and still have good outcomes, what do? We update the recs. And I think that's a differentiating factor for our group is we haven't made static one-time recs. In fact, we're living that now. These are our new recs that we just updated last week, like it was, Thursday last week, based on new data from the state. We had new surgeries, new data, and you don't have to get in the weeds other than to say, if you look at the ones for which we had data before, and you look at that box all the way to the right, you see that we have reduced prescribing from anywhere from 10% to 63% in our recommendation based on real data from real patients. So we're doing this in a way that I think is satisfying for surgeons because they see it and they say, oh, those are my patients. That's actually my surgery. And we're putting this out now for the first time for knee and hip replacement. This would represent a 50% reduction for knees and about a 75% reduction for the hips. These unused pills, as we've heard, matter. I would tell a story of a woman that I met in South Bend whose sons, who were very famous hockey players in town. High school hockey is a big deal in South Bend, and their kids, her 2 boys were, one was number 5 and the other was 25, and they're now the 525 Foundation because they both passed. They took a couple pills, drank a couple beers, and didn't wake up in the morning on graduation night. And I had heard it from my friend who introduced me. He's a surgeon, and I had been introduced and heard about, many people talk about the severity of the epidemic, but what was really striking about his introduction was he said, I knew these kids. I knew I'd never cared for them or their parents. But when I read that article in the newspaper, I wondered in that moment, did my excess prescribing directly lead to the pills that made it to that party that night? And if you're prescribing right now in what you believe to be excess of what people need, you should feel that same level of responsibility. I don't think we can simply throw our hands up and say, well, people have to be responsible for their medications, dispose of them, which is hard, and secure them, which many don't think about. We got to take some personal responsibility. Why would we prescribe more than what we think people need? What does that look like in our state? You guys remember this slide? 33 extra pills, 1.8 million surgeries. That's 62 million pills in excess each year from surgery alone. And this would be better if we had won. But that's what would happen. That's 1 year's excess prescribing just from surgery, not including dentistry. And we'd need about 3/4 a Yost. It's a huge number of pills we prescribe in excess. I will point out that while we're reducing prescribing, I don't believe we're just directly pushing people to the street. I think many of the people who are moving down the path of heroin and fentanyl are driving down that path because of addiction is far, far down the path. I think what is happening and where most of that flip is happening and where the challenges are happening is in misinterpretation of the CDC guidelines and primary care physicians who are choosing to not prescribe anymore because they're scared, but not because that's what the guidelines say. Ooh, that did not come out nicely. We have actually done big drives, and I'll just point this out quickly to say that, that we have an incredible team who actually organized a 60-city drive this last fall. We got about 3,000 pounds of pills, about 3,200 pounds of pills, 40,000 opioids. We see codeine dating back to 1972 as our oldest. It was 1976 before. And surgery and dentistry. So surgery is the biggest, but dentistry is the number 2. I was to say, what's the second most common reason for people to show up with excess pills? It's dentistry. 75% of the people getting out of their cars at our drives here in Ann Arbor and our surrounding groups where we collect these data come in from excess pills from surgery or dentistry. We have made brochures. You can go to our website to find these brochures, and some of you have. We have a lot of dental clinics actually using these now. And I'll point out one important factor, because we decided this about a year ago. We realized that people wanted them, but they were trying to replicate our brochure rather than just using it. We just want you to use it, and we'll even up the game a little. If you want your logo, even if it's Michigan School of Dentistry, University of Michigan School of Dentistry on the front, we will, within a week, we have a standard operating procedure. You send an emailed thing with your high-resolution logo. We'll put it on the front of the brochure, and we'll give it back. And we have about 100 health systems in 20 states. I think it's about 20 states. And we have one in Ireland using these branded brochures. They're free, they're available, and you can have them within a week. And this just shows you the surgery one. We have one for dentistry and oral surgery that is tailored to that. Ramesh was helpful in helping revise that. Here in the state, on the back, it'll show you how, give you information on all the FDA, I'm sorry, the CDC, DEA, let me get my acronym right, the DEA registered sites for safe disposal in our state. Wrapping up here, well, what do we really want to do? And I think you guys fall into this first bucket. We've done a lot with reducing prescribing after surgery. But our bold new move for this next year, what I'm really excited about this next year for surgery and for dentistry, is to say, where are those examples of where we could completely eliminate the exposure? Because we're not seeing overwhelming effect sizes between the number of pills prescribed and these outcomes, these morbidity outcomes. The exposure itself seems to matter. So decreasing or eliminating exposures is really where we need to be. When needed, we want to decrease it to get it better matched to what people need. We believe that new persistent use should be a complication that we can eliminate, that even when we prescribe, if somebody's moving down that path, if we can address it earlier and get better transition of care back to their primary care physician or an addictionologist if needed, we can stop people from going too far down the path. Too often in an acute care setting, we treat people for 1 month or 3 months. Everybody's got a different standard, and in doing so, probably make things worse rather than just getting some help earlier. We want to do this in a way that manages pain and enables functional recovery. If we think about just some good practical guidelines for today, I think that right now educating patients is probably the most important thing you can do. Telling them that, hey, this hurts a little. And it's going to hurt for a couple days, 3 days maybe. And the opioids aren't there if you're going to prescribe them to take away your pain, but they're just supposed to make you, they're supposed to be there for severe pain. I want you to be taking acetaminophen and ibuprofen around the clock, and I want to ask you, can you afford that? And if you can't afford it, would your insurance pay for it? If you're a Medicaid patient, it's probably cheaper for you to go with a prescription to the pharmacy than it is to go buy a bottle of Motrin. So I'm going to give you that script today, right? And then I want you to check learning to check the PDMP and avoid co-prescribing. of benzodiazepines. If you are going to use an opioid, I only use one short-acting opioid. Do not give people multiple opioids. I don't know how often that's happening in dentistry and oral surgery. Orthopedic surgery, it's happening all the time. People going home with 3 different short-acting medications, and they get very confused. I would never, ever give a person who's not using opioids a long-acting opioid. So I would not give them an MS-Contin, OxyContin, or a fentanyl patch as a part of their care. That can lead to serious morbidity. I avoid pre-operative prescriptions, and by that I mean if you've got a patient scheduled for an extraction, don't give them their opioid prescription in advance of that extraction as a means of convenience. They may start taking it in advance of their case to help treat that pain, and we see this as an independently associated risk of new persistent use in virtually every cohort we look at. So the people who fill before their index case have higher rates of new dependence. Certainly, probably a couple factors there, the patient more interested in taking it and a provider more willing to give it. But even within that, I do believe we're also getting people acutely tolerant. And think about naloxone prescribing if you have a high-risk patient. We have to stop this from happening. We have to. I really don't want to hear more stories. It's a tragic situation. And we have years ahead of us. And this is not going to be a quick fix. We believe that we can do this through getting data. We have worked with Blue Cross Blue Shield, at least within the surgery world, to reward and guide change. We've talked a little bit about this within dentistry and oral surgery. I find the finance and reimbursement to be dizzying for what you do. But I would love to think about opportunities where Blue Cross Blue Shield of Michigan might be able to incentivize dentists and oral surgeons to perform better, because that's what they've done now for surgeons. We have a modifier 22 that increases the professional fee by 35% if they follow a care pathway that includes education, encouraging acetaminophen, ibuprofen, and a reduced number of opioids. And it's gone incredibly well, and it's improving patient care, not just reducing prescribing. And we have to collaborate. We have to be in this together. These are my colleagues. Mike Inglesby is a transplant surgeon and director of medical education. Jen Walge is a hand surgeon and a health services researcher, and easily the most effective person I know. This picture might be a little dated. We've got a few folks in the crowd here today. Kind of got to throw your hands up. We've got the most incredible team. I think we're just now 3 years old, and we've been sort of cranking along. So I'd encourage you to go to our website up top, especially if you want the patient materials or you want to see any of our guidelines or information, and then some of our work with Precision Health. So with that, I'll say thanks. He's the boss. I will handle questions if he wants me to handle them.
Sure. I'm retired, so it comes up very rarely. Even though I practice, I didn't do any surgical extraction. Wasn't an issue. But when I thought someone needed an opioid, I would normally prescribe Vicodin. Is that less risky than the others?
Sure.
What do you think of Vicodin?
Sure. So the question is, I think the broad question is are there opioids that are less risky? Yes. And I get this question frequently. In fact, I'll get it from orthopedic surgeons frequently about tramadol. Is tramadol less risky? Many people don't even recognize that tramadol is an opioid. And what I'll say is that in the UK, they have a tramadol epidemic because they don't prescribe a lot of oxycodone or hydrocodone. So tramadol is addictive. Hydrocodone is definitely addictive. For sure, without any ambiguity, is addictive. There are many who believe that oxycodone, oxymorphone, and some of these more potent medications might be more addictive. We don't see it in our data as we think about things like new persistent use or the potential for addiction per se. I think what we don't really fully understand and we are working on in our group is some of the pharmacogenetic differences between individuals as it relates to metabolism. Some people may not get the same bump from metabolism, from the metabolism of hydrocodone, which does have an active metabolite. So you might only be getting the hydrocodone, not the norhydrocodone or some of the metabolites that are active. So it may differ within an individual. That said, every opioid you're right, from codeine, tramadol, all the way to oxymorphone is addictive.
Okay, the second question then is, when we prescribe a combination of acetaminophen and ibuprofen, to be honest with us, and for us to be honest with our patients, how effective is that really compared to an opioid?
Sure. So the opioid acetaminophen combinations and how much benefit are you getting from the acetaminophen?
No, from the non-opioid. When like Michael said, when you prescribe a combination of, I forget what
of an NSAID and acetaminophen versus an opioid?
Yes.
Yeah, so the data show that the acetaminophen and ibuprofen together are at least equally effective, if not better, especially if you account for things like nausea, vomiting, and sedation associated.
Or is this making the facts fit the political situation?
So I never make facts fit a political situation. I probably ran for high school office once, and I probably made facts fit that election. But otherwise, I have not stretched the truth here. Those are randomized controlled trials published in your literature, and I think one of our important goals here is to try to, I think there's a lot of people who have maybe missed those, and are the studies all perfect? No, but Ramesh is going to show you even more data now from your own clinics to suggest that that there's real opportunity to decrease or eliminate prescribing. Yeah. Yeah. So I'll be quick here because I want to make sure Ramesh shows these data. I almost made it out without talking about marijuana. CBD is within marijuana you have or cannabis you have THC and CBD, and there are many, including my mentor and colleague, who believe that CBD has a strong role in future for pain. What I think right now we know is that we haven't studied any of it well enough. And the CBD could offer a real opportunity, especially for those that can't tolerate NSAIDs. So I think there's something about that anti-inflammatory effect and the potential pain effects. I am a huge believer in deregulating cannabis for better research because we have equated it to heroin and it's not. Yep. Show your stuff.
Folks, I'm going to take about 5 minutes, okay? Because I really want you guys to know some of the stuff that's happening in this institution. So, the nationwide data suggests that about 46% of opioids prescribed in dentistry are not used, okay? So what I want to tell you is Kenny, Chad, myself, and some others, we've had a project at this school calling back patients who had procedures at high risk for opioids. So first we looked at everything, and Jean is here, and I want to say that none of this could have happened without Jean and all the data pulling that she did. And we identified the particular procedures that were most commonly associated with opioids, and then we called back patients who had those procedures, whether or not they had opioids. And then we compared those groups, okay? And what we found is for our number, we're an academic institution. In this state, we've had a lot of legislation, so we had hoped that we'd be a lot better. So our number is about 65% used, 35% unused. So when you think about precision prescribing, we're still way off on this. And actually, one thing, step back, about 19% of patients who received an opioid never filled the script. Okay, so we're really missing the mark in terms of precision prescribing. And just like Chad and Michael and Rebecca have talked a little bit about the unused tablets and what a risk they are, and I don't know if you know this, but they are bought and sold in high school like candy was when I was a kid, right? So the risks with this is that 35% is contributing to that reservoir that can then be bought and sold in those ways, right? But what I want to tell you is, like I said, we call back every patient. I'm going to get Kenny here, who made a lot of the calls. Maybe Kenny, for 30 seconds, if you could talk a little bit about what the patients were saying when you spoke to them. You have no real dental background before, so I wonder if you could say a few words.
Yeah, so typically when we call, when we called the patients, whether they received an opioid prescription or not, or whether they felt that they had gotten more pills than they needed. So we had one question where we asked the patients if you felt like you received about the right number of pills, less number of pills than you needed, or more pills than you needed. Whether they said less, about right, or more, all of them typically said that they were satisfied with their care overall. So I think that dentists have a huge impact on the patients, and they'll kind of go with whatever the dentists kind of tell them to. So I think that you guys have a big way that you can impact the patients.
Thank you, Kenny. So, as we know, we are a huge gateway to first opioid experience through wisdom teeth and taking care of kids who are, 10 to 25 and whatever. So, we have a critical role to play in the opioid crisis, actually. And I will steal a line from Chad. I am also guilty of contributing to this crisis because before, when I didn't know better, I did not want my patients, I measured satisfaction in the moment. Like I wanted my patient to be happy over that day, over that weekend. But now the way that we should approach these patients is I want them to have a good life. And now with all these known risks of opioids, we should rethink our prescribing. If I take you back to the ICE demonstration that we had, and I'll pick on my two friends, Bonnie and Sherry, who are asking a lot of questions, how long are we going to do this, what's going to happen? What if I said, we're going to do this for 3 minutes only? It's going to be uncomfortable. You may not have expected that because you've never had this ice holding thing before maybe, and it's going to be surprisingly uncomfortable. But it's not that bad, and it's going to be for 3 minutes only. What I'm talking about is educating our patients more about expectation and then rethinking what we actually prescribe to them, okay, instead of hammering them with opioids. So you'll see here for routine extractions and for surgical extractions, there's not much difference, okay? This is by the way, this is unpublished data, so we want it to influence practice, so we want you to talk to your colleagues and change practice, but we don't want to post it all over the internet. All right, and here, I'm not sure if you can see back there, so let me describe it. The blue is the non-opioid group. The red is the opioid group. Towards the right is when Kenny and friends called, they said we had no pain. Look how large the column is for no pain, and the second column is minimal pain. A lot of the non-opioid group are there, right?
And Ramesh, all the figures, a lot of the slides have gotten kind of flipped, and so the red is the people who got opioids. So the red are the people who were prescribed or filled an opioid compared to the blue who didn't, because it's kind of at the bottom, you can't really see.
Yeah, it's a little.
So
the red is the opioid group and the blue is the non-opioid group. And this is routine extractions, but actually the story is quite similar for surgical extractions also. You see that the people who had a surgical extraction but told Kenny they had no pain. And that's the non-opioid group, the blue there, right? So we have to really rethink what the needs of our patients are. I want to skip through because if you have more questions, I want to take those. This is patient satisfaction. Just like Kenny said, there's actually no statistically significant difference between satisfaction for the opioid group and the non-opioid group. The left column is routine extractions, the right column is surgical extractions. You'll see that the standard deviations overlap, and there's actually no difference, right? Because satisfaction is not necessarily the number of pills. It is more those things of education and some of the stuff Dr. Brummett talked about in terms of the Zing train and how you treat each other and how you treat patients and that sort of thing. So we need to develop this topic more. We're sort of out of time today. I'll remind you to sign in at the back to receive CE credit. I want to thank Dr. Robert Green, who said to me, Ramesh, you've got to talk to Michael Herman. So thank you for that, Dr. Green. And many thanks to our three speakers, Rebecca Haffergy, Chad Brummett, Michael Herman, and also to Kenny Slosh.